Welcome to the Code of Life. I'm Randine Neal. Every year, Genome BC holds the Don Ricks Distinguished Keynote Address featuring BC's most important and influential scientists. This year, the topic is COVID-19. And the scientists on this year's panel have become household names in BC. Dr. Bonnie Henry, of course, Provincial Health Officer, Dr. Mel Krajden from the BC Centre of Disease Control, and Dr. Carl Hansen, CEO of AbCellera. This episode answers all your questions about COVID, from how quickly we'll have a viable vaccine available to all Canadians, who decides who gets it first, to how this pandemic will change science for the better when it comes to fighting to cure other diseases like cancer. This episode is moderated by CEO of Genome BC, Dr. Pascal Spothelfer.
Thank you for sending in your questions to Slido. And also as a reminder, you can upvote questions so they rise to the top of the pack. And our apologies in advance, we only have an hour. So we will probably not get to all of your questions, but we'll do our best. So let me start with our first question. And it's for you, Bonnie. So Dr. Henry, are we going to go into lockdown if the cases continue to rise?
You know, that is a very good question. It's something that we're all concerned about, particularly in the last few weeks as we've seen numbers increase, particularly in some parts of the province. But I would say in British Columbia, we never went into a lockdown in the same way that we've seen in other parts of Canada, but certainly in Europe and other parts of the world. And our plan from the very beginning of our restart was one way. And what we want to do and what we are doing is learning about where this virus is being transmitted and where the super spreader events are happening. And we're titrating our response to make sure that we can reduce those possibilities and keep open the things that are important. And we talked about that a little bit, about how important it is for our healthy communities to have schools open, to have workplaces open as much as possible. So we're focusing on the COVID safety plans, and now's the time we all need to go back and look at those. We're focusing on the things that we need to do individually, and right now, that means keeping our groups small. It means not having Halloween parties. It means not having large weddings and gatherings in our homes when we can't maintain those safe distances. Because those are the things that we're seeing now that this virus is being transmitted. And we will continue to do that. And the other part of it that allows us to keep this going is the tremendous work of the public health teams doing the contact tracing. That helps us find people, understand where transmission is happening, and keep us open and moving. But it is everybody. We need to regroup. We need to keep our social connections small so that we can continue with those important things in our community. And it's up to everybody now. It's up to all of us to do our piece now.
So in that you're using a number of tools, and one of the questions is, and I'll direct that to Mel, is how genomics and genomic data is helping to inform public health and policy decisions.
For this virus, it was very helpful to be able to sequence the genome of the virus very quickly to help inform us about the location, whether something was being imported into the province. That's a little different now with the borders closed. But the use of genomics is largely to try and understand if you have an outbreak, are there multiple sources to that outbreak, or are they from a single source? And can you link that in a very rapid fashion with the testing, the results, and the contact tracing?
So a question for Carl, and Carl, Eli Lilly had a pretty big announcement that is affecting AbCellera this morning. Congratulations. And so one, if you want to comment on that deal briefly, and an add-on question is whether other companies use a similar technology as AbCellera, and what makes your technology unique?
Sure, thank you for that, Pascal. So for those that don't know, this morning there was a press release from our partner Eli Lilly, which we're working with to help develop a therapeutic antibody for the treatment of patients that have been infected with COVID-19. That particular drug is being tested for multiple patient groups. That includes patients that are in the hospital, patients with mild to moderate infection that are not yet in the hospital, and also prophylactic treatment for those patients that are at highest risk in care homes to make sure that we can prevent infection spread for those patients that are most susceptible to getting sick. So a few weeks ago, we had an announcement of an interim phase 2 data that suggested that the treatment of the mild to moderate patients, those that have been infected but have not yet become very sick, allowed for a very substantial reduction in the rate of hospitalization, so approximately a 70% reduction, which in these types of trials is a very big signal and reason for hope. Based on that, Eli Lilly had made a recommendation for emergency use authorization, which is still pending with the FDA. And we are, optimistic that will come forward soon, although of course it's not in our hands. This morning there was an announcement that an agreement was made between the FDA and Eli Lilly, or the U.S. government and Eli Lilly, I should say, for the purchase of 300,000 doses and the ability to ratchet that up to 1 million doses over the next half of a year. So that is an important step. And I think very laudably, Eli Lilly has communicated their policy on pricing and availability, where they're going to be distributing this drug based on need amongst patients in countries all over the world. They're going to make sure that it is distributed in a way that does not cost patients. So the governments are going to pick up the cost. And also they're going to change the price in relation to the ability of governments to pay. So I think that is exactly what one would hope would happen. And we're very proud to be part of that collaboration. So still one step left. It still needs to be approved for all that to move into action. But we feel like we're on the verge of having contributed a therapeutic that could help millions of patients. So that was the first part of your question, and I probably already talked at some length. The last part was, are there other companies with our technology? The short answer is no, that it's a technology that was developed here in BC, and in fact, originally at UBC, based on some funding from Genome BC when I was a professor at UBC. Since then, we've expanded around that and built many other technologies that help to build a complete workflow from the definition of a drug discovery problem to a final therapeutic. There are other companies doing great work all over the world in a similar space, but ours is unique and we believe has some significant advantages in speed and flexibility. So maybe I'll leave it there.
Fabulous. So talking technology, Bonnie, when will we activate the COVID app in BC? So the COVID app, a federal initiative, and I think it was deployed in Ontario. And so what about BC?
Yeah, this is one of those challenging things. We've been talking with them from the very beginning about where an app would be helpful and where it has not been shown to be helpful, let me put it that way. And unfortunately, it was developed by people who didn't have the public health perspective in mind. And we have been working with them since the spring when they first looked at this. There were a number of apps developed in other countries, and a couple of other provinces, particularly Alberta, had developed one in-house that they were evaluating. But this one took over, and I do believe it is rational for us to have one app in the country. The challenge we have is that right now it does not meet the needs, and it's causing some challenges for those provinces who are using it because they have focused rightly on privacy, but that means that there's no way of actually determining what we would like the app to do. Let me put it this way, is to be able to notify people who were within 6 feet of a phone who has it. So we don't need to, we notify a phone that's within 6 feet of a phone at particular times when we know there's risk. Right now, it notifies anybody for 14 days prior to somebody becoming ill. And we know that people aren't infectious for 14 days before they become ill. So what that means is there's going to be people, and we're seeing this play out in Ontario, who get this notification, you've been, and another problem we had with it was the language. It says you've been in contact with somebody with COVID. And that's not true. What it means is your phone was within 6 feet of somebody at some point where they may or may not have been infectious. So we have asked repeatedly for them to at least limit the time frame that these notices go out. And what we really would be useful would be to supplement our public health contact tracing, to be able to say, I want to send a message to people who were within 6 feet of this phone, or phones that were within 6 feet of this phone between 9 o'clock on Friday night and 1 o'clock in the morning when they were at this event. And so far, we've not been able to have a meeting of minds about how to make that happen.
More work
So
is
I have no
required.
problem with the app, and if the federal government will support people and follow up and answer all those questions that come when people get a notification, that we have no way of telling them what the risk really is with this one. So it's unfortunate.
So the next question is around vaccines, and I'll redirect the first part of the question to Mel, and then the second part will go to you, Bonnie. So Mel, do you believe we'll have a vaccine ready in the first part of next year?
Certainly there will be vaccines. I think the question that we're all trying to solve is what is the safety of those vaccines and whether or not, with the current viral infections, there's very good evidence that you're losing the antibody very quickly. And so the question will be, does this vaccine actually produce a good antibody response or an immune response to the vaccine? And then is it going to be protective? There are some concerns in the literature about whether or not prior exposure to non-COVID coronaviruses could interact with this vaccine. And so there's a lot of work that needs to take place to make sure that these vaccines are safe and they do provide the immunity that they need to. And then I'm sure Bonnie will explain some of the other challenges about how do you deploy the vaccine, who do you deploy the vaccine to.
That's actually exactly the next question. So what criteria will be used to guide the administration of the COVID vaccine and its distribution?
Yeah, so there's a couple of things, and this is, and I talked a little bit about ethics and ethical principles. So we have a National Advisory Committee on Immunization in Canada, and they have been focusing on identifying if and when a vaccine is ready, how do we best make sure that those most in need receive the vaccine first. So we do have priority populations, but what we're wrestling with, as Mel said, is there's several different vaccine candidates, at least 7 or 8 of which are very likely to become available in the first quarter of next year, 4 of which Canada has some stake in. But they're not going to be available in large amounts to start with. So we need to figure out who is the best population to start with. And obviously the people we want to start with are those who are most at risk of having severe illness from this. We want to make sure healthcare workers are protected, other essential workers, people who are at risk by their environment, so certain congregate housing, certain communities. So there is a framework, an ethical framework that we're working through nationally to make sure that we can do that. And of course, the other part of it is the logistics of how do we get vaccine to people. Some of the vaccines that are in production require fridge stable, which is what we're used to. Our vaccine distribution is able to handle that. Some need -20 and some need super -80 deep freeze. So we also don't yet know which vaccines are going to work best in which populations. Will they work as well as in older people and younger people? And that will change our strategy a little bit. But those are all things that we are working on.
So one of the challenges seems to be that we're every time there is another step, it's into unknown territory in a sense. So now the unknown territory, for instance, is, so how are we going to vaccinate all Canadians in a very short time? Carl, you had to gear up very quickly to do the antibody screening. So probably a question for all three of you is, what kind of steps would you recommend should we take for the next pandemic so that we're ready? Each from your different perspectives, be it from private industry, being from the lab side or from a public health side. Who wants to go first? Is that one? Carl,
I'd
do you
be
want to
happy.
take that on?
Yeah, so maybe just to set that up, a little bit of background to what happened recently with COVID-19. So we have been able to contribute a therapeutic that now stands at the front of the pack in the world for a therapeutic antibody against COVID-19. And that came on the heels of a sustained investment by our company to build antibody discovery capabilities, and in particular, a 2-year effort with the Department of Defense that was specifically focused on rapid pandemic response. So over 2 years, we pressure tested the platform, we made connections, we figured out the bioinformatic, the data transfer, all of that. And it was because of that we were able to move so quickly. I don't think we're anywhere near where that technology can go or where that preparedness can go. And so one of the things I think this really highlights is that not waiting for the emergency, not being back on your feet, but rather knowing that there will be something like this in the future, that it has the potential to be very disruptive. And that by preparing for it, by getting the science, the technology, the relationships, the policies, even the response in terms of allocation of funding to relieve financial stress, all of that could be done ahead of time. And if anything, this is probably a wake-up call. So from our perspective, we see this as the very beginning. We are going to continue to build up capabilities. And I'm confident that, should it happen again in 5 years, 10 years, 20 years, hopefully longer, we'll be much, much better prepared than we are today.
Yeah, I'd say that's a really good basis to start. And when things are going well and public health is doing its job, we're easy to neglect. And we have whittled away our public health systems. We've whittled away our ability to do coherent surveillance of diseases across the country. And we don't have the depth and redundancy and surge capacity in our public health workforce and experts in disease tracking and epidemiology and all of the important things that we have in place. And when the tyranny of the urgent in acute care comes along, it's very easy to whittle away at public health. And I'm hopeful that this will remind us again how important it is to have that workforce, that buffer zone, that safety net that public health plays in many different aspects of our communities. And this pandemic has shown again how important it is.
Well, I'm a firm believer in data integration. And the tools that have come together in British Columbia are a step forward. But if you think about what the challenges are, it's our ability to know who's infected, where they are, were they tested, were they negative, were they positive. And that information has to feed back into the contact tracing and the rapid response to enable us to open our economy and to do so safely without lockdowns. It's that same tool, those similar tools are the ones that you require to measure whether someone got their vaccine and what's the long-term outcome for their vaccine, and monitoring that and integrating that piece of data. What's clear to me when we look at those systems we use, you can go to a grocery store and you have the barcode and it's all linked. And we're still very paper-oriented in our system, and it slows the process. So I think we need to take a bite from modern technology, adapt it to our health system. And I think having that kind of information, I think helps inform industries like the one, AbCellera, to look at what's going on in the system quickly and then respond.
Yeah, it's kind of it ties into another question that is coming in on Slido. Is we had the SARS pandemic in 2003, and it has led to some changes, like PHAC, the Public Health Agency of Canada was founded at that point. So what might be the legacy of COVID-19?
From a public health perspective, I hope it is being able to realize a public health information system that allows us to integrate the information we're collecting across the country. That was a dream that came out of SARS-1 that I was involved in. but we never realized it. And we are seeing the challenges that we're facing now. We all have different ways of collecting the information, putting it into a database and sending it to the Public Health Agency so that we have a national picture of what's going on, whether it's the lab testing. And so, I'm hopeful that will finally move ahead. I think I do want to recognize that we're many steps ahead of where we were in 2003 in terms of guidance that we're providing, working together across the country, sharing information, but we're not yet where we need to be. And we also, of course, have recognized there are parts of our system that we have failed, including long-term care, and we need to take a different approach to integrating long-term care into our healthcare system. It's always sort of been a little off on its own, and that puts people at risk, and sometimes the people who are the most vulnerable in our populations.
I would just like to also add that I think what Carl and his company has shown is you need a long-term investment into people, and highly qualified people who are across many, many disciplines. It's laboratory, it's epidemiology, it's public health, it's scientists. And it's through that kind of interaction that you can be prepared. And those individuals have to be doing day-to-day work, and then they can be called on during an epidemic.
Yeah. You use the word investment, and I think that's one of the key questions. So from a public point of view, we tend to forget the cost of unpreparedness, and then we don't put the money into the preparedness. And from an investor's point of view, to more the private sector, Carl, how long is the memory of the investment community to actually invest in the preparedness and into companies that contribute to preparedness? In your case, it was DARPA that investment. It wasn't venture capitalists.
Yeah, that's a great question. I was going to answer the previous question and say that the silver line, one of the silver linings of this will be that it has really put a spotlight on infectious disease research, which in biotech is an area that has been tough to get funding and resources to for some time. Whereas certainly everyone here, and I think if you just look globally at what some of the biggest problems are, infectious disease remains one of the big problems that faces humanity. So getting more effort and technology on that problem is something that has happened already. And I suspect, you asked about memory, I suspect that will not tail off right away. So there's going to be, it'll be a decade before people start to be as complacent about drug-resistant bacteria, new viral pandemics, even the viruses that come around seasonally that are a problem. So that would be my first response. And you also mentioned DARPA, and it's just sort of as some interesting backstory of that. There's another agency, of course, BARDA in the U.S. that does some of the larger translational work and has been heavily involved in the pandemic response. In fact, BARDA was started by a venture capital group in the U.S. many years ago, and they made investments and got that agency going, but didn't stay the course, because one of the challenges with pandemics is that they don't come every year, and it's hard to maintain that long effort. So, finding ways to boot up the public sector effort and the private sector effort, and have them working on things that are adjacent, but where the capabilities can cross over, I think is the most effective way. And we have no shortage of infectious disease problems, so I'm hopeful that will be an area of growth moving forward.
So let's get back. We talked a little bit about the future. Let's go back into more of the present. Mel, if you could have like a wish list of things that you could implement right now to improve the response of your agency, what would it be? Where do you see the gaps that you need to fill?
Well, it's a long wish list. I think part of the challenge is to streamline the process whereby someone can get tested. And what's clear is having people in a lineup getting a swab in their nose is uncomfortable. So one of the efforts we tried was to try and use these saline swish and gargles. It's bringing that information and testing either it on-site rapidly or through a system rapidly, but also the individual getting their result immediately by text or email, and some of that's already been created. But it's also taking that sample and then doing the whole genome sequencing so you can understand, okay, where's this transmission occurring from? And then relaying that information to the public health group so that they know where they need to focus attention. So it's all of these pieces that come together, and then as a society, we are going to have climate change, we are going to have changes in vectors, and it points to what Carl has highlighted, that infectious diseases are going to be transmitted. Having this capacity is the way we can react more quickly in the future. And that's what I believe needs to happen, and I'm hopeful that some of the legacy of this event will be some of that integration and the infrastructure to do it.
Yeah, no, I'm with you there, as you know. But I think the other things, I mean, I think you made a comment, we were talking earlier today about, we've sped things up in pulling things together in ways that, haven't broken laws of physics. So that we've shown that you can do things in a more coordinated and quickly and safely. I would like to see right now, if I had my druthers, I'd like to see us all being able to enter in a piece of information once and use it where we all need to use it. We still don't have that. And having more, we've evolved, even in BC where we only have 5 geographic regions and PHSA, and we've managed to evolve so that we all have our own little systems, and we have had with a crisis like this to pull those systems together. And if we, not only the IT systems, but I'm talking about the cultures and the way that we do things and the people and the way we're structured in our health system. Each health authority is structured slightly differently, and that, when you're dealing with a crisis that's affecting all of us, can become a barrier, and it can slow things down being able to manage. There's a good way of trying different things and supporting people, but what we found with this virus and this pandemic is that you need to be able to be nimble in moving surge, whether it's people or testing capabilities or understanding different outbreak responses, and we're still struggling with that, and we need to do better.
Mel, you mentioned testing, and I haven't checked the underlying kind of implication of the question itself. So, Dr. Henry, why is the BC testing rate significantly less than Ontario, Quebec, or other countries?
Yeah, you know what? Because we're not focusing on testing rate as a metric that actually it can be not particularly helpful, to be honest. Our testing strategy has focused on making sure those people who need a test get it as rapidly as possible. And we've evolved our testing strategy, and we've been very open about that. At the beginning, we had limited capacity. We needed to focus on understanding when we were having introductions. And then when we moved to restricting travel, we needed to focus on the health system, protecting the health system. That meant we tested people who were likely to end up in hospital and healthcare workers, because we had, again, limited capacity. And our testing rates went up. We were like about 8 or 9% at the peak, with very low testing numbers, meeting our capacity, and that was good. That meant that we were testing the people that needed it. Through the summer, as our curve came down, and we had and the other viruses went away. At the time that we were testing, at 8%, most of 100 tests that were done, 20 of them were influenza positive, and one of them would be COVID positive. So that was making things complicated. In the summer, we didn't have influenza. We don't have a lot of the other respiratory viruses. So we opened up our testing again to anybody with symptoms. And we focused on that because we knew that there's no way to really find asymptomatic people unless they're linked to a case or a contact. So our asymptomatic testing was focused on outbreaks, being able to understand long-term care homes. We had an outbreak in temporary farm workers and shared accommodation. We had outbreaks in poultry processing plants, in correctional facilities. And anybody who was exposed and at risk, we did testing in that group of people. And now, as we're heading back into cough and cold and flu season, we need to refocus again. We need to focus on ensuring that children are assessed when they go to school, and people at work, and people with the right constellation of symptoms. Because we have learned from Ontario, we've learned from Alberta, that when you do a whole lot of asymptomatic testing, the yield is exceedingly low, and it uses up a lot of resources, some of which are still in short supply across the country, so reagents, for example. And now you've seen that Ontario, Quebec, Alberta have all pivoted to be more aligned with what we're doing now too.
Just a quick comment to say that it's not, you can't test your way out of everything. And part of the challenge is being able to be focused in what you're doing and learning what is the best strategy. So I know that there's the movie industry and other industries where testing has become a tool to try and induce that safety. We need to learn what is the best strategy.
So one of the things that is being approached now with the federal government having bought these rapid tests is to open up travel using testing strategies, etc. But it seems the rapid tests have the problem of not being that reliable. So, Colin, that might be a very difficult question to answer. So you're able to identify an antibody that is obviously effective against the virus in relatively short time frame. So why is it so hard to develop a test that actually is acting rapidly and reliably with the right level of specificity and sensitivity?
That's a terrific question. It's one probably Mel will also have some insight in, but there are multiple challenges. First, you have to decide what exactly are you looking for, and there are different types of tests. Some that try to detect a virus, some that detect a pre-existing immune system. And then to detect the virus, is it an antibody-based test or a genetic test? All those methods can work, and they all have different time frames. But once they are developed in a format that is point of care that someone can easily do, that is inexpensive, manufactured and distributed, that's a big part of it, but not the only part. One also has to cross-validate it and get the clinical studies to make sure that it is accurate. All of that takes time. So I know that when the pandemic first came out, we all wanted to have these tests immediately, and they were much too slow compared to what we would want or what we needed. But at the same time, when they did come out, if you look at the regular time it takes to develop these tests, it was very fast, as everything has been in this pandemic. And the only way to make that faster would be to put some real effort into innovation and technology that was somehow different, and to have the pre-existing networks in place, as well as capacity to manufacture. On our front, it's for therapeutics, and that was laid. The foundation of that was laid through the U.S. government, and then supported by the government of Canada when it came time to really, accelerate the work and make sure that we could continue our work at social distancing. Maybe similar things are required in the testing side.
Which comes back to preparedness. I'm sure you have a comment on that, Mel.
Well, there's been a tremendous amount of discovery in the testing sphere, and I'll just give you an interesting example. So with the normal PCR test, you have repeated cycles of heating and cooling. Well, there's these isothermal tests, and so one of the solutions for third world countries is you put it under your armpit, and it keeps the temperature and allows you to do the test. And I just say that facetiously, but those are some of the things that you need to bring together in terms of technology. I think ultimately what you need to be able to do is improve the sensitivity of the antigen tests and the point-of-care nucleic acid tests. There are some that are now being available, such as the Abbott test that has been purchased by the federal government. And we just, again, need to figure out where do you use it, which populations are best served by it, how do we get those results into the system so public health can know what's going on in the province? And those are some of the challenges.
And we've been talking about this because we know we're going to get 2 different types of tests available in BC very soon. And some of it will be helping us understand what's going on in rural and remote communities, in particular First Nations communities. If we have a cluster of people who are sick, it takes sometimes days to get an NP swab down to the lab. So the ID now would be a perfect one, the test to have at the health center, where you could do it. It's not high throughput. You can only do maybe 3 or 4 an hour. But if you do 4 or 5 and they're all negative, that is, the negative predictive value is pretty good, and it's probably not COVID you're dealing with. If you get 1 positive, then you know that it's COVID. So being able to use it to help identify outbreaks, whether in schools, whether in long-term care homes and more remote communities, those are some of the strategies we're looking at right now.
Some of the issues also, that virus is not the same virus that we had back in February or January. So these tests and the vaccines, the question is also, will they continue to be effective against the specific virus as we know it today? So it's kind of two questions that came up. It's kind of the evolution of the virus since it was first detected earlier this year or late last year. And do you observe any significant changes in the strains of the virus as we have this spike now compared to the one that we had in the spring?
So this virus tends to mutate fairly slowly, typically 2 mutations in a month. And compared to the original strain that was found in China, the strain has evolved from, there's one particular mutation, the D614 to G mutation, that has basically now circulating globally. And that region does affect the spike protein, which is important. And I think the notion of genomics being able to monitor for these changes and mutations, and that understanding how these might affect the vaccines and things like that, is a component of the kind of surveillance that the system needs to ensure that it hasn't mutated in a way that will impact the immunogenicity of the virus and also the vaccines that are being produced.
So let's shift gears a little bit and move from the science to the social sciences aspect of that pandemic. So now the kids have been to school for about 2 months or so, and based on what you have seen, Bonnie, do you think we have to make adjustments to the protocols that are in place, be it from an epidemiological point of view or be it from a just operational point of view?
Yeah, this is something that we're watching very carefully, and we've had from the very beginning. We've said we're going to be working very closely with schools, and our role in public health was to put in place the basics of the different layers of protection in a school environment, and then every school has done things slightly differently depending on their size and the structure and the building and the ventilation and other things. So it is in some ways a way to understand which are the important factors. So we have been monitoring and we've been posting publicly every exposure event. So anytime somebody, whether a staff person, a teacher, an educator, or a student was in a school environment during their infectious period, we've been posting that and we've been following up on every single one of those. And they reflect, and what we're learning, which is what we understood, it reflects the transmission in the community. So communities where there's more transmission, there's more exposure events in schools. But we've had somewhere in the vicinity of 200, and we're probably up to about 240 exposure events in close to 3,000 schools, 600,000 children, and another 35,000 teachers and staff. And we've had half a dozen where there's been a transmission to one other person in the school, and we've had 1 outbreak. So I think we're learning a lot. We're going to learn a lot from that outbreak. It's in a school in the interior, and it looks like there may have been more than 1 exposure event that went unrecognized. But the investigation of each of these has helped us understand that the measures that are in place are working. It's been stressful, and I get that. It's stressful for parents. I actually think that the kids are the ones that are doing really well with this, and they're adaptable, and they're figuring it out, and they're wearing their masks, they're keeping their distance, they're modifying their games. I was learning some ways that the kids were modifying games to be able to safely play. Instead of tag, it was shadow tag, things like that. But it's been really hard for the staff and teachers, for public health, and we're getting used to it, and we're working through it together. And so far, I think it's been a tremendous success. And I'm really, my admiration and gratitude goes to all of the teachers and educators, the principals, and the staff in the schools that are making this work, because it is so important for kids.
Yeah, I mean, Carl, you, as the CEO of a company that has probably more work than you ever had in the past, you must very much appreciate the fact that the kids of your staff can go to school and what difference it makes. We have also seen that women particularly suffer under school closures professionally. So, Carl, what do you see from, if you look at your staff, from a burnout point of view?
That's a great question, and you try to watch that closely, obviously. I'd say there's two competing factors there. One is the intensity of the work and the pressure and the stress that is layered on top of all the things you just mentioned. So having to deal with social distancing and being at home and childcare, which has been going on not just recently but since early March, when this was really the most intense. The other counterweighing factor is a galvanizing effect amongst the team, pulling together and feeling like they're actually making a difference in the world. And I think that goes a long way. So, I personally, as a CEO, could not be more proud of how everyone has pulled together, tried to cover for each other when there are things at home that require someone's time, and really, delivered on a problem that the whole world was working on, and did it almost flawlessly, and it needed to be done flawlessly. So as I said earlier, resilience is one of the things that I really took away from that. Now that things are going a little bit back to normal and kids are being able to go back to school, it definitely takes the pressure off. But I'd say by no means is the pressure completely off. So I'm still very, very wary of that. And one of the other things that we haven't really touched on, or is a little bit different, is it is challenging to maintain a tight team when you don't get to see each other in person. So trying to find opportunities in suitable spaces to get the teams that work together to come and make that personal connection. It makes the communication better, and you feel much more part of a unit. And I think that's one of the really important things that many people are feeling across many industries.
Yeah, and I think there has been a lot written about, the days of the office are over, and we'll be working from home in the future, etc. And I think the longer we go into that, we realize how important these daily personal connections are, and how much we inspire one another and energize one another through the personal contacts, and that's not happening in a virtual world. So I think before we kind of shut down all the offices, I think we want to live through that and then see how we come out of that. And talking about pressure, I mean, the BC Centre for Disease Control is under tremendous pressure these days. It's because we forget COVID is just one issue you deal with. The other issues you're dealing with on a daily basis are not going away. So how do you manage at the BC CDC, Mel?
I think it's a similar concern. So there's a concern of staff and their families, and that affects the ability to do the work that needs to be done. All of the gaps in terms of the processes that exist within our province are amplified. In the early phase of this epidemic, pandemic, what happened was the hospitals were shut down, and so and physicians' offices were seeing patients, so that you could reshuffle staff. And now, as we try to maintain a fully functional healthcare system, that does create demands on the system. And it highlights that without some of the use of more effective technology, that you can lead to staff burnout and overworked staff, because it's just an enormous amount of work, because everything is important. And there's a bunch of unintended consequences, like the sexually transmitted diseases are continuing. So even though they're wearing masks, they still engage in certain contacts. So I think that it's important to keep a holistic and comprehensive support for your healthcare system.
And that leads me, it's also a combination of questions. One of the challenges is, if we look at the population, you alluded to that, Bonnie, there is very different populations in BC. There's also fragmented healthcare system. There's different health authorities, and there is people who live in Vancouver where healthcare is readily available, and there is people living in remote communities. There is parts of the population that are dealing with much more underlying conditions than others. So from a public health point of view, how do we address these inequities and make sure that we all get the support from the public health care system that we require?
And I think that is incredibly important. And I mentioned this a little bit earlier, that this pandemic has really exposed a lot of inequities in what we call the social determinants of health. We know people who are living in poverty are more differentially affected. We know Indigenous people are. We know that there's systemic racism in our healthcare system that makes many of them feel it's not safe to get tested for COVID if I'm sick, or to go to the hospital. So those are all things that have been exposed through this pandemic. We know that many of our essential workers are not just healthcare workers. There are people who do the chicken processing, or drive the fruit and produce, or the gas in from other places around the world, or these important things. And we know that that other populations are infected. So we very much have an underlying ethical framework for how we're making sure that we can make it at least accessible to everybody as equally as we possibly can for those in need. And some of that has driven things like our testing strategy to make sure that we do have it available for those people who need it in a safe way. It also has driven some of the communications that we're doing in public health, and how we provide information about where cases are happening, because we have an overriding obligation to protect people. And we see that for some people in a crisis like this, it brings out their stigma and othering of people. And we saw that in behavior towards Asian populations, towards certain other populations that have become affected. And we see it now in some school exposures where people are telling their contacts that they tested positive, and they're getting nasty messages and notes. And I've seen it personally. So we have to make sure that how we do things continues to build trust, so that people are able to come forward and get the care they need when they need it. And that's an overriding thing that we've been working on in public health.
So we have about 5 minutes left. Oops. And I would like to close off with a question. I haven't prompted you for that one. So if you think ahead 20, 30 years, and you are rightfully retired perhaps, and you sit on the porch and you talk to a grandchild who says, so you lived through the COVID-19 pandemic. What stood out the most for you? What do you think your answer will be once you look back with a healthy distance from what we are living through right now? I probably should have prompted you for that.
Well, actually, I'll give it a try. Just thinking about that now, it occurs to me that hardly a generation has gone by in recent history, certainly, if not long history, where there hasn't been some very dramatic event, something that people will remember. It could have been World War II. It could have been World War I. It could have been Spanish flu, which came shortly after World War II. So very often there are things like this, and I suspect COVID-19 is like that. Thus far not as horrendous in terms of loss of life as some of those that I just mentioned. Economically, comparable certainly, and I think one of the things that probably always comes out is that in times of crisis, you get to see people's mettle. You get to see, do they stand up? Do they work together, and do they find solutions? And while we haven't been perfect, I think there's many examples where we have done that. And we've done it in BC. It's been done in the US. It's been done in other countries. Not perfectly, but if we were to try to look at the glass half full, I think there's a lot to be proud of that's been done so far. And I'm hopeful that we'll come out of this better calibrated for the future. So That's what I'd say.
I'd say, this pandemic will define 2020, but it won't define us as a population. And we have learned about resiliency, we've learned about adaptability, we've learned about that there's still joy in the midst of this tremendous uncertainty that's going on for a long time. We've seen heroic people supporting each other and communities coming together. And we have an opportunity that we've exposed some inequities in our culture and our communities, and we can take this and build back better and more just. And I would like to be in 20 years saying this was a turning point where we recognized how we could be a better community, how we could be more just and more fair.
I think one of the things that this event has done is brought out both the best of people and also you see some of the worst in people. But in listening to the radio this morning and hearing a mother, hearing a woman who is in an old age home and how important it was to be in contact with her family and to be able to have those human contacts, it illustrated why we're here. And we are here to help each other, and really we need those human and social contacts to make the world better. And ideally, we want to focus in on getting the best of us in the future.
I really appreciate the conversations that we had in the context of this Don Rick's keynote address. And I think reflecting on your comments and so you come here, you have given very generously your time to us, and you have proven to be so reflective on this stressful situation. And I have to admit, I admire your calm amid the storm for all three of you, because what's going on is unprecedented. It's in a sense it's frightening, and on the other hand, we also know at one day it will be over. And we'll go beyond that. And I can only tell you how grateful and glad I am to live in a place where there are people like you who do this tremendous amount of work, be it in the private sector, be it in the BC Centre for Disease Control, or be it as our public health officer. So I can only thank you for what you do on a daily basis. Thank you for joining us here, and for giving us all the opportunity to learn so much more about your work and what you do.